what mobile stroke units do, of course, is to treat patients with thrombolytics faster. That's their main rationale and main effect. And all the studies have shown the same thing with mobile stroke units, that they do treat patients faster and more often, and that results in better outcome. And the improvement in outcome is just as great as was achieved with thrombolysis compared to placebo. So it's a big treatment effect by getting patients treated faster. So I think that and particularly in the first hour or so, because the clots get dissolved faster. So the real problem with mobile stroke units is not the question of whether they work or not, but the logistic issue and the financial issue of getting them funded and paid for. At least in the United States, our healthcare system, any new drug or device has to get paid for by the insurance company in order for it to work. And so when you have a drug company making a new medication or a device company with a new device, they go to the FDA and then to Medicare to get reimbursement, FDA for approval, and then Medicare to get paid. So the most recent example of that is with the new Alzheimer's drugs, right? There was a debate initially whether they should get covered by insurance because the clinical effect was minimal. But the newer drugs are going to get covered because there's more of an effect. Well, the problem with mobile stroke units is they're not a device and they're not a drug. So there's no insurance companies don't have a pathway to reimburse them. So we have to create mobile stroke units as a entity, as a place of service that Medicare recognizes. I know that sounds like, well, just say it, right? But unfortunately, it's not that simple. It's going to require actually a congressional act, an act of Congress, to say mobile stroke units are a place of service in the pre-hospital setting that can be reimbursed. And then Medicare can do it. But as you can imagine, getting an act through Congress when we have all sorts of other issues in the world going on, wars all over the place, this takes a relatively backseat to other more important things. So until then, mobile stroke units, are just difficult to pay for because they don't get reimbursed. And they are cost effective in the sense that improves outcomes. So our downstream costs are less. And so they do meet all the various cost effectiveness thresholds that we use for new treatments, which differ from country to country. But if somewhere between $50,000 to $100,000 per quality adjusted life year is usually, that's the old threshold. It's usually considered 3 times the gross domestic product of a country is what is considered per person the appropriate quality. So, in the United States, it could be as high as $200,000 for quality adjusted life year now. But certainly mobile stroke units fall below that threshold of cost effectiveness in countries. So we just have to figure out a way to get them reimbursed. That's the problem. How governments look at it in Europe, like for instance, the mobile stroke in Germany is paid for in part through government funds. And so I do think that possibly if we get reimbursement in the United States, that then it will have an effect on other countries being willing to reimburse them as well.